Great talk, thank you. I hope that these tests will be available in Europe soon. We will start our panel discussion. I would ask the audience members to come to the mics for questions and the online audience to post questions. So I will start with the audience question to Giuseppe concerning whole body MRI. Isn't there a need for more prospective evidence, especially as ASCO guidelines include whole body MRI as one choice of next generation imaging based on 36 published papers with only one of them about whole body MRI?
Yes, of course, there's a need. We pointed out in the talk, there's a strong need of more evidence. There are just a few papers with limited number of patients. So we have an estimate of the figures. As you have seen, we know that there is some upstaging and downstaging, but that's it. So we need more papers. Probably a partial explanation of that is that the technique was not very well established until the latest years. So there were some technical challenges that limited the widespread use of this technique.
Thank you. Stefano?
Yeah, also, sorry, I have a question for Giuseppe. Well, first of all, congratulations for being brave to come here and talk, starting with a 15% only of supporter. Now, the question is very simple. Why you think, I'm a great supporter of whole body MRI. I guess it has a great potential, especially now with shortening the duration of the scan. But it's very difficult to get access to that. As you showed, you propose a multicentric trial and only 3 centers in Italy adhere, and you are the most considered radiologist. So what is the problem? The problem is that lack of tomographs, tomographs too busy with other indication, laziness of radiologists, difficulties at interpreting the scan. What is the real
All three that you mentioned are a problem. really, and we are here to discuss, and I'm glad to hear your comments, because MRI availability. Because until now, the scanning time was roughly 1 hour. So in 1 hour, it's more profitable if you do 3 knees instead of 1 whole body MRI for the institution. This is one point. Then laziness of radiologists, because, with the whole body MRI, you have to make a proper reporting, you have to look T1 with different contrast, the Dixon, the fat fraction, the diffusion, the ADC map. You have to combine all together, so you end up having hundreds of images. And I can tell you, if I take, let's say, 10 radiologists, only 2 like to do that. They like easier task. That's why with AI are solving the first problem, we are cutting the time. And also with AI, I'm really pushing it to do single image reading. Because one of the beauty, I believe, but you can tell me, of PET is that it's easy. So anyone can look, an oncologist, you don't need to be a specialist of the field. You can understand if there is an uptake. So we're trying to understand and learn the lesson from PET and make in one single image your diagnosis. So these are the 2 comments.
Thank you. Nick?
Yeah, it was a question primarily for Thomas, but actually also for the imagers. So discussing about post-operative radiotherapy, and you didn't say it explicitly, I don't think, but essentially the assumption is that you're doing this PSA recurrence-based, not imaging-based. But particularly, as with our surgeons, they don't do node dissections. The imaging then becomes very sensitive for detecting recurrence. So in my practice, certainly, I don't do it PSA-based. I do it imaging-based because that allows me to pick the volume. And also, we know from 3 randomized trials and a meta-analysis that deferred treatment is probably better than immediate adjuvant treatment. So we literally never do adjuvant treatment. So I just wonder what your comment was on how you integrate imaging into your decision-making. And obviously, it's not just for you, it's for the imagers as well.
Yeah, so that's for sure. So we need to, especially in the post-op setting, when we have a patient in the salvage setting, so we need to include also PSMA PET-CT. So the EU guidelines suggest that when we have a PSA of more than 0.2, we need to restage these patients. Of course, if the question becomes, if you see something, it will be probably easier to propose a treatment. So we have data now suggesting what we have to do in these cases. Probably it's a little bit more challenging to adapt and to decide what we have to do when we have a PSMA negative patients. And of course, this should be mostly based on the evidence that we have, and for recommending whole pelvic radiotherapy, we have just one trial, so the sport trial that didn't include the PSMA PET-CT. So I think that's for sure that we are integrating more and more PSMA PET-CT imaging in this setting.
Nick, to just respond, I would say that the sensitivity, as the data was shown, when you have a PSA less than 0.5, right, it's closer to 20 to 30% sensitivity. I mean, it's terrible. The POP-RT trial in localized disease was PET negative nodes, and that's the only trial in INTACT that showed a very large, actually, for distant METs, there's a hazard ratio of 0.35. I mean, I've said this before, I personally, because there is no level 1 evidence, I think, and I've said this and I'll be bold again, I actually think it borders on unethical to wait till imaging, because on PSAs of 0.2, we know that the imaging 70% of the time will be negative, and that is the most curable state of the patient. And so when you look at all of our oligomet trials of one MET, it's about 90% of them long-term will recur. So you're basically, to me, you're waiting for enough cancer cells to be present. Many of them will then be metastatic, and you are missing your window for cure. So I would say until there's a randomized trial validating your point, I would say that the standard of care is you should treat when it's microscopic. And also in the Radicals RT trial, the distant METs and PCSM favored the adjuvant radiation arm with a statistical p-value. So it was not that adjuvant radiation therapy was no different, it actually was worse.
That's not quite how...
No, the p-value, if anyone here can go look, the updated paper is significantly worse. The PCSM and the distant METs is like a p-value of 0.06.
Yeah, I was going to say, just in relation to the imaging, though, we're back to the earlier point about the timing of the trials in relation to the timing of the imaging. Because Radicals, I mean, I think, to be honest, I do think the take-home message from the Radicals trials is that deferred treatment is equivalent to adjuvant, which is why that is in our guidelines in the UK. But it was done in the context of a world where there was no PET. So we're back to, so we know that deferred is okay, I think, but we don't know how deferred is okay, and we don't know how imaging integrates in with it, was the point I was making.
To comment on this, so I agree with Dan, that question of deferred wasn't the question in the Radicals there, it was only that early salvage, so that was meant with deferred is better than adjuvant, and also there are no randomized trials, but many other studies showing that the earlier you treat at lower PSA values, the better the outcome. And that's why the EAU guidelines also clearly state that negative PSMA PET should not delay treatment if somebody needs salvage radiotherapy. Boris?
So one question to Dan. I think your talk was very convincing that genomics are really precise, but that still depends on the histologic area where you take the test. So if we don't hit it with a biopsy, then your genomics are not as precise. So I think that if you have standardized PET reading with promise criteria, that has a pretty good AUC as well with regards to overall survival from the promise registry. Did you, in your trials or what's going on now, compare now genomics to PET? Is it really such a difference as you suggest, or combining it seems really, I think, promising, because right now we have different perspectives. We have more experience and longer follow-up of PET in Europe. In the US, you have more follow-up with the genomics, but now you're picking up with PET. So this is, I think, really an unanswered question where we don't know the additional value, and they're both expensive, so it's a decision we have to make.
Yeah, I would love if someone could share with me a phase 3 randomized trial with PSMA PET and 10-year distant METs outcomes. I haven't seen one. So basically, your statement can't be true because there's no data. So I would say it's unclear. The other thing is, without tissue, this goes to Dr. Attard's early comment, there is far more than just the prognostic genomic signature. There's many, many other things that are developed, like predictive signatures that some you may hear from, well, actually, Gert, I can't even remember. I see all this data, if he showed it or not, but there's predictive signatures I think he did earlier for docetaxel and maybe for ARPIs. So to me, it doesn't need to be one or the other, but I would just say that PET is probably prognostic. I'd love to be able to see the radiomics in a long-term follow-up with the SUV or whatever you want to use, and maybe that's good. Maybe it's good enough. I just need to see the data.
Anders?
I have a comment about salvage radiotherapy because as urologists, we get the patients back after salvage radiotherapy. And there are more and more salvage radiotherapy performed. And we see more and more complications. I fully agree we need randomized prospective trials. But I'm afraid there is a risk that we maybe treat too many patients with salvage radiotherapy. We must know better exactly who we should treat because we see more side effects, fistula and other things.
Yeah. You could have just avoided the surgery and then you don't need salvage radiation. It's fine.
Well, sometimes the only thing that will cure a patient is the knife. You know?
There's a question from the online audience to Daniela. What is the evidence for using contrast CT with PSMA PET-CT? So would you recommend always using a contrast?
Thank you.
CT?
Well, PET-CT is a hybrid imaging technique, and as we know, we can combine PET, the metabolic part, with CT, and this might be a low-dose CT or a diagnostic CT with contrast enhanced. The advantage of using contrast-enhanced CT, it is that you already have the diagnostic CT with your PET. So actually, you can combine anatomy with metabolic information. And I think this is important, and we should perform this. On the other hand, I have to say that also because of the availability, because we want to scan faster and to scan more patients, and also because of the patients having I would say contraindications for contrast, we don't do this standard in all the patients, so there is a variation.
Okay, Ursula?
Yeah, it's also a practical issue. I think if we, also for clinical trials, I mean, if we have a baseline double contrast CT, then we can keep on monitoring them as well, not using PET anytime. And also, I mean, really aggressive disease where maybe this SUV uptake is not that excellent, we might miss visceral metastasis or something else when we don't do the contrast. So this is actually what we agreed on in our center, and the radiologist has to be on the side of the nuclear medicine physician to give us the details, of course, of the report.
Thank you. We continue with...
Sorry, just the contrast PSMA takes a lot longer to read. There's a lot more information on it. And just the genomics trial, sorry, against PSMA, you'd intervene with the PSMA scan, so I think it'd be very hard to design that because you would intervene. So my question's about whole body MRI from Dublin in Ireland. Disclaimers, I have a couple of whole body MRI publications from 20 years ago, but I'm a PSMA fan. I was just wondering, the big problem was diffusion imaging and specificity. I mean, whole body MRI would be very cheap to do. I'd love to do it.
Yes,
but
so
the specificity is the problem.
So if you read the figures on the available data, the specificity is not lower than any other technique. The big problem is not the specificity. It depends who is doing whole body MRI. So that is the problem. The problem is the training, because if you just look at diffusion, it is a mistake. You always have to look at diffusion and conventional imaging, NT1 and T2. So if people do not have enough training or experience, they just stick to diffusion images. And if you call metastasis everything that is bright, you're going to lose your battle. So thank you for this comment, because you're pointing towards what we discussed. Training is extremely important. Now I believe it will be easier with the modern technology.
So it's my opinion from my previous experience in whole body MRI is that it mightn't be as good in nodal disease, but be very good in bone disease.
Yeah,
so that's what I would think.
Yes, it's not only your opinion, which is right. Also, data show this. On bone is, it's a common experience that, and we have a large data on bones. It works very well. For lymph nodes, it does not work well. I don't think any technique works well for lymph nodes below 5 millimeters. You can read any paper. We are not able to see below 5 millimeters, even with PSMA PET.
Well, I would see now in PSMA PET quite a few kind of 2 millimeter nodes that are boiling hot. I could warm my hands on them. They're so hot. But I don't know. I am a fan of whole body MRI.
Yeah, good.
Thank you. Silke?
Yeah, I have one short question for Dan and maybe also for Glenn, because we made now our pathologists always report if there is a presence of cribriform or intraductal carcinoma. We have not that much experience with Decipher, as you know, in Europe. So do you think this adds prognostic information or presence of one of them? Or you think Decipher is so good that there is no more need of having all that pathology on the pathology report? Because I guess that's something we ask our pathologists.
Yeah. I would say two things. So one, actually, right behind you, Ganesh, the pathologist that, not Ganesh, but the pathologist at University of Michigan, Rohit Mehra, published a paper on intraductal and cribiform and Decipher, and basically there's immense amount of genomic heterogeneity even within intraductal tumors. What's interesting, we just presented at GeoASCO on 10,000 patients, Decipher plus digital pathology. And so in 10,000 patients, there is actually zero independent value of any traditional tool, PSA, T-stage, the Gleason score, et cetera. Now you can argue, obviously, you have to have a biopsy of the tumor, but basically everything falls out. So Decipher alone, its AUC without any variable, just on its own, is about 0.8. So it's better than NCCN risk groups, just that variable. So I'm not saying you can't have an amalgamation of nuanced pathology to get similar, but that's not something every pathologist right now, we're lucky even if they can get the Gleason score right in community pathologists.
Yeah, no, right. And I guess that excludes pure small cell neuroendocrine.
Correct. I don't know of data. Yeah.
We
Separate.
have time for one more question by
Just
Ganesh.
a quick comment and a question. Dr. Spratt, always making friends. So if any of you want his personal cell phone number later to harass him, let me know. I'll be happy to give it to you. Philosophical question to the panel about the rapid evolvement of molecular imaging, next-generation imaging. The beauty of the genomics, tissue-based genomics that Dan has been eloquently talking to us about is that you can go back on archive-based tissues, already completed trials like they've done in NRG, and be able to ascertain a contemporary outcome on historically treated patients in a way that we can't do with imaging. So much of what we are seeing now, I'm concerned about the Will Rogers effect, that's certainly happening. So our expert panel, how do you all reconcile that? We are finding more and more minute phases of the disease. We run the risk of overtreating those patients like we did many of the lower risk patients. So how do you all manage that or reconcile that in your own mind? And any thoughts for us about moving forward? I mean, it'll take decades before we find out some of these answers that we can't really redo all these trials, or maybe we can. But thoughts on how you deal with this? Because as a urologist, I see this stuff and I wonder, I don't know what to make of all the other prior data was based on imaging that we don't even do anymore.
Thank you. Short answers, please. Ursula?
Well, I memean, the problem is, of course, first the availability. So I think we have to learn and implement it. And as you mentioned, for some examples, I mean, the duration of ADT added to radiotherapy, et cetera, is especially in patients that are at borderline for doing long-term or short-term. I think these are clinical decision-makings where it helps us in patients that are not fit for the standard treatment or the standard treatment that we know so far from the trials. I think it's additional information that we have to learn to live with and share with patients, but I think it's not yet ready for the community practice, let's say.
We only have time for one more answer. Thomas?
So I fully agree with you, Ursula. So there is a gray zone to recommend adjuvant radiotherapy in this setting. So I think we have data, but sometimes we have patients that are in this gray zone, which we don't know if we need to recommend or not the ADT in the salvage post-op setting, and especially for how long. So now with Radicals HD, we need to put the patient on 24 months or nothing. But of course, we have also data using 6 months. And personally, I think that some patients, we have many open questions. Probably genomic classifiers will help us, even in this setting, to better define the duration and indication for ADT.